We are back and going to talk now about the EFAST exam, EFAST Plus exam. So this exam is something that is incredibly useful both in low risk, high risk patients. Really captures a great deal of information about the patient and their clinical stability. So this is really your bread and butter of emergency medicine ultrasound. If you can perfect this, you can make your life a lot easier. We'll talk about how this can easily rule out a pneumothorax or effusions in the lung or blood in the lungs, as well as evaluate for blood in the belly. So what are you going to use for this? I typically will put my hands first on this probe, and the reason for this is it's so versatile. You can use this on the chest or on the abdomen by simply changing the depth of your image. You don't have to switch around probes. So this is the one that I would suggest using for all of this exam. Where are your images generated and where your locations? So chest wall, anterior chest wall in supine patients is going to be extremely sensitive for pneumothorax. Air rises, so use this to your benefit. Right on each side of the sternum, you put that probe on and evaluate for lung sliding. Here are your flanks. So this is where you're going to be capturing the diaphragm on each side of the chest. This will let you know if there's fluid above the diaphragm or below. That diaphragm serves as a really highly acoustic specular blockade, so it actually allows ultrasound beams to come all the way to it, strike against it, and go all the way back to the probe. So if there's any water interface on each side of this really highly echoic structure, you're going to be seeing that quite visibly, and you'll see in these images how quickly the water or the blood, depending on the situation, jumps out at you. Subxiphoid view, we discussed that earlier, and then your suprapubic view. So these 6 views are going to capture a ton of information for you. We'll start in the right upper quadrant. Again, this might be a refresher for most of you, but notice here in the left lower portion of the screen, your liver and your kidney interface. There is a rib shadow right in between your Morrison's pouch, and that's where you're going to be directing a lot of your attention. I'll show you a video in a second, because this is not an uncommon circumstance to get that rib right at that spot where you really want us to look at. I will highlight on the bottom right that that inferior pole of the kidney is also a particular point of emphasis in terms of visualizing that. I've seen a number of cases where there's fluid in the belly located solely right at that inferior pole for some reason, the way the ligaments of the belly shape out that force fluid into this region. So make sure you're seeing that Morrison's pouch above the liver, between the diaphragm and the liver, and then that inferior pole and fan all the way through. Again, this is the side of the body you're going to be using this. This probe marker is facing towards the head, always to the head or to the right of the patient with the EFAST. So this probe marker is to the head. And this is a nice, comfortable movement. You notice how the hand isn't flexed. It's not taut. Nice, comfortable movement back and forth. This is just rocking back and forth, looking in the right upper quadrant. And this is the image you're going to be generating. That nice pleural interface here. Here's your diaphragm. Notice your spine is this bright white echogenic material down here at the bottom of your screen. And again, this rib is sitting right there at that Morrison's pouch, but you notice as you fan through, you get a nice view of that interface of Morrison's pouch. You can confirm that there's no free fluid there. Again, the other thing you can see is this inferior pole. Catch it right here at the end. Beautiful. Right at the end, no fluid. There's nothing above the diaphragm. We'll talk about the spine sign now. What is the spine sign? You guys have heard that with x-rays before. Notice that that bright white hyperechoic spine stops right at the diaphragm, does not extend above it. This is normal. That is the most common thing that you'll see. If you see spine going above the diaphragm, then you know that something is amiss. Something is allowing ultrasound beams to go all the way from your probe all the way down to the spine and make it bright and echogenic. So in this case, spine going above the diaphragm, and there's a large pleural effusion here with a consolidated or atelectatic lung floating in the fluid. Again, something is letting ultrasound beams come all the way down. If this lung is aerated and normal, the beams will stop way up high and not be able to come all the way down across the body and hit that spine. So this little area down here is the most important spot to look for. Normal, abnormal. Notice that spine jump right out at you. Positive or negative? Positive, right? So Morrison's pouch right in the middle here of your screen, interface between the kidney and the liver. Notice how free fluid is sharp. This is a major feature, one of the few things that if you take home from this talk that will be really useful for you. Really sharp, jagged, rigid, diving into crevices, physiologic fluid that's in cysts or bladders or stomach is going to be smooth and nicely contoured. This is sharp and irregular, so that's suspicious for blood or ascites, depending on your clinical situation. But this one, notice that inferior pole of the kidney. This is subtle, but there it is, right at the inferior pole, that triangular, sharp collection of fluid. That's free fluid as well. Notice the spine at the bottom of your screen doesn't extend above the diaphragm. Inferior pole, very important. Is much more subtle. You see that stripe of fluid between the kidney and the liver. You can also see, if you're careful, at the end of your image, you can see that spine go above the diaphragm. So this patient has fluid both in their belly as well as in their chest. So this absolutely may change your management or help you with guiding your surgeons. There's fluid in the chest, right up in the corner here, and if you slid your probe towards the head, you'd probably see a nice bigger chunk of that fluid. But you're sitting in the flank, that probe is marker is facing the head. And here's your fluid in the belly and in the chest. How about this one? Get this one. Don't even come to the course. You are way ahead of the game. Way ahead. So here's your right upper quadrant view. You have your liver here on the left. You have your kidney, your spine. You look between the kidney and the liver. There's this material here. It looks slightly less echogenic than the liver. Do you notice the difference? It's not that homogeneous liver. Could it be abnormal liver signal? Absolutely. The right setting, however, if you have a trauma patient and they're unstable, or they, especially if they had trauma a good amount of time ago, this would be suspicious for clotted blood. Remember that the only time blood's going to be nice and anechoic and bright, and dark on the screen when you notice it and noticeable is when it's fresh. Blood that is sitting in the belly or wherever in the chest for quite an amount of time will clot off. As it clots off, it generates more echoes, internal echoes. So when ultrasound comes down and hits it, it doesn't go through it, but actually sends signals back to your probe. So this is going to be it's going to be less anechoic and carry more echogenicity than fresh blood. So this patient had trauma, I think 6 to 8 hours before this ultrasound was done, and had already started clotting some of that blood off. Left upper quadrant, a little bit different. We highlighted the Morrison's pouch, which is between the kidney and the liver. Left upper quadrant, pay most of your focus, or really direct your focus above the spleen. So suprasplenal is going to be your highest yield area for free fluid. That's not to say that it can't collect elsewhere, but if that's the only view you can get, make sure you have the patient take a deep breath, watch that diaphragm come down into your view, and look for fluid above the spleen. This is your probe. It's going to be usually more superior and posterior than the right upper quadrant. Oftentimes your hand will be on the bed. As you can see here, it's like laying right on the cot. Here's your motion, this nice sliding up and down, again comfortably holding the probe to slide right up and down, and this is the image you'll generate when you do that, sliding up and down. You go through the entire three-dimensional structure. There's a nice picture at the beginning. You have your spleen on the left, kidney on the right. That curvilinear bright white line here is going to be your diaphragm. Notice the spine does not go above the diaphragm, so this is normal. No free fluid there. It's a good, really quality image, as opposed to this image, which is also quality but scary as well. So you have spleen here sitting in a bath of fluid. If you're also careful to notice, look below, above the diaphragm here, there's also anechoic material here and what looks like the spine down here. So this patient has fluid above and below the diaphragm. This is the inferior tip of the spleen. You notice we talked earlier about the inferior pole of the kidney. That inferior tip of the spleen can sometimes harbor some fluid as well, as it's doing here. How about here? Fluid in the belly or fluid in the chest? So get your landmarks, right? So here's your diaphragm right in the middle. It's your spleen. This is below the diaphragm. And here's fluid above the diaphragm. So this patient has fluid in the chest and does not look, at least not in the left upper quadrant, not seeing a lot of fluid. So that patient had a large hemothorax in the left. Fake out here, so you're in the left upper quadrant. Here's your kidney right at the beginning. Here's your spleen hiding out here. This, for someone that doesn't look at a lot of ultrasounds, might be suspicious for free fluid. Think for a second of what else is in that left upper quadrant that could be causing some dark or fluid-like echoes, be anechoic. Notice how it's circular and smooth. The contours are not sharp. Here you go, right here. It almost looks like a cyst. Sitting right in this corner crevice of the kidney and the spleen. As you fan through, this is actually your stomach with some stomach content. So just be aware that if you're seeing something that's suspicious, notice its shape and regularity, and if it's circular and smooth, think about where it is on the body. In this case, this is a normal stomach, or probably a stomach with a little dilation to it. Lastly here, before we move into the chest, is suprapubic, so both longitudinal and transverse views. Here's your transverse view. Notice that nice rocking motion back and forth. And you can twist here to your longitudinal view and then rock back and forth. This allows you to really interrogate the entire three-dimensional structure. So you're seeing both walls on each side as you fan through. Here is this in real time, again, fanning through, changing to the longitudinal. This is a female. You can see that uterus sitting right behind the bladder. You could probably turn your gain down and turn your depth down a little bit to lose all this kind of schmutz back here. It's another view. Fanning back and forth, back and forth. This is going to be a male patient. Notice you can see the prostate right in the posterior aspect of the bladder. Right here, the circular prostate. It's not a uterus. It doesn't extend. Here's your uterus. Notice how it extends all the way from the front wall of the bladder to the back wall of the bladder, all the way back and forth. Female patient. How about some positives? So right off the bat, here's your bladder. Again, smooth contours. Notice the difference here. This is sharp. It dives into the crevices of the intestines, which is this stuff here on the left. It's irregular borders. It's diving all the way dependently in the belly and in the pelvis, right adjacent to the bladder. This is a long axis view of the bladder, so that's a positive fast scan with a significant appearing amount of fluid. Likewise, here's another patient. Here's a transverse view of the bladder. Here's what's likely the prostate here. Could be the uterus if you looked in longitudinal, but regardless, you have fluid here posterior to that. You notice how, again, fluid's going to be dependent and sharp and angulated. Looks like triangular back here. So that's in the pouch of Douglas area. A bit more subtle here. Again, fanning through quickly. Right at the end there, you see that fluid right in the back aspect of the bladder. Here it's nothing, nothing, nothing. Then boom, right there in the side. There's your sharp, delineated anechoic stripe of fluid, which again in females may be normal and physiologic. In males, you should not ever have any of that. This is a small amount of fluid, but in a trauma patient that's unstable, this is very concerning. The right situation. What can you do if you're unsure? You can follow the patient with serial ultrasounds, look at older ultrasounds, etc. Here's another picture. Again, fanning through, seeing if there's free fluid. You don't see a ton there. You're fanning all the way through the bladder. Again, that gain is kind of high. I'd probably turn it down. How about here? Look on that left side of the bladder. There's your free fluid. Boom. Wow, that's a lot. Here's your intestine moving here on the left side of your screen as well. So this is a positive scan. You can see how the importance of fanning, especially in the suprapubic views, can really lend itself to success. Here's some movement through. I don't see anything there. Transverse, you actually fanned, looks like pretty well all the way through. I'm not trying to scare you with those, but that was looking normal. We talked earlier about the subxiphoid view. I won't go over this a ton again, other than to show you some anatomic features. Subxiphoid, again, liver is going to be up here. Here's your pericardial sac. It's bright white. Your right ventricle is going to be closest to the probe. Your probe is up here, remember. So the first thing you're going to hit is your right ventricle. Then your right atrium there. Your left ventricle is the largest. And your left atrium is adjacent. Positive subxiphoid views. We went over effusions. Here's your black effusion anechoic. Effusion above the pericardium there. Another positive effusion. This is a trauma patient, so this is actually blood around the heart. Likewise, blood around the heart. Again, as you see more and more of these, you can see how you can easily pick them up. It becomes very much pattern recognition. This patient, similarly to the one we discussed earlier with the right upper quadrant, notice how blood clots, and you'll see this. This is actually a heart here, liver. Here's your pericardium, this bright white up here. And then between your heart and your pericardium is this mass, this kind of globular mess. Some of it looks fresh and black and anechoic. The rest of it carries this texture to it, which is actually clotted blood. So this is a hemorrhagic tamponade. You can see just a minuscule amount of movement in the heart. So this patient had a stab wound to the chest and was in PEA arrest with barely any heart activity. And this was actually called a negative scan. This was not at an institution, thankfully, that I was at, but at a colleague's institution. And this patient did not have their chest cracked, which you could argue should have been done, although the mortality would be astoundingly high either way. So we've gone over that. Lastly here quickly, we talked earlier about how where you want to place your probes when looking at lung sliding. Notice here it's just right side of the sternum, and this is your image you're going to generate. You make your depth smaller with your nice trans-abdominal or curvilinear probe. Here's your pleural line. Notice that bright white pleural line. Here are your ribs here on each side, and this your lungs are sliding back and forth, back and forth. What does it look like in close-up? Some people say it looks like ants marching along. Not really sure about that. Like little signals, little reverberation artifacts coming from your pleura. This is normal lung sliding. You can see the difference between the superficial aspect of the screen, which is just soft tissue, compared to this movement down here, which is consistent with lung sliding. As opposed to this image, again, soft tissue here. Here's your pleural line. No lung sliding. Does this equal a pneumothorax? Absolutely not. This suggests that there is no lung sliding in this particular area. What else causes no lung sliding other than a pneumothorax? Bunch of things, right? So atelectasis, that's really socked in, and pneumonia, that's really socked in, pleurodesis. A good amount of things cause lack of lung sliding. A big bleb on COPD as well. The only thing that's going to definitively call a